I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Summer can be hard on the skin. We face bug bites and blisters, rashes and redness. Today, summer skin struggles. This is the People's Pharmacy with Terry and Joe Graydon.
Warm weather invites lots of outdoor activities, from hiking and swimming to biking and barbecues. How can you protect your skin from sunburn, blisters, bug bites, and rashes?
Dr. Chris Adigun is the People's Pharmacy dermatologist. She's standing by to answer your questions about how to protect your skin from warm weather woes.
Do you have a dermatological dilemma? Our lines are open for your questions at 888-472-3366.
Coming up on the People's Pharmacy, solving summer skin problems.
In the People's Pharmacy Health Headlines, roughly half of American adults have elevated blood pressure, and many people struggle to get it under control. Nighttime is particularly tricky. Higher than normal blood pressure overnight is associated with a risk of stroke, kidney disease, or heart attacks. Doctors worried, though, that having patients take their blood pressure pills at bedtime would lower overnight blood pressure too much. They need not worry any longer. Chinese scientists conducted a randomized trial of 720 people with hypertension. They assigned these patients to take their blood pressure pills either at bedtime or upon waking throughout the 3-month trial. Bedtime dosing controlled overnight blood pressure better without pushing it too low. People taking their pills at night also maintained good blood pressure throughout the day. The medication that was used in the study was a combination of olmesartan and amlodipine, with dosage adjustments as necessary.
Because of the widespread abuse of opioids, many physicians substitute a medication called gabapentin to help control acute or chronic pain. This drug was first approved in 1993 to help treat epilepsy. The brand name, Neurontin. The FDA has also approved gabapentin for pain that lingers after a shingles attack. But many doctors now prescribe this epilepsy medicine for migraine headaches, nerve pain, anxiety, restless leg syndrome, fibromyalgia, hot flashes, and post-surgical pain. According to our calculations, roughly 12 million Americans take gabapentin and its chemical cousin pregabalin on a regular basis.
A new study published in Regional Anesthesia and Pain Medicine raises concerns about the risk of dementia for people taking gabapentin. The investigators analyzed medical records of more than 52,000 adults with chronic low back pain. Half received a prescription for gabapentin, whereas the others got different pain relievers. Those who received 6 or more prescriptions for gabapentin were at higher risk for mild cognitive impairment or dementia. The association was strongest for elderly patients who are already at a higher risk for cognitive decline. Other side effects of gabapentin include drowsiness, dizziness, confusion, and depression. No one should ever stop gabapentin or pregabalin suddenly because there's a potential for withdrawal symptoms. The authors of the latest research encourage prescribers to monitor their patients closely for signs of cognitive decline.
A study of dietary habits found that people who follow a MIND diet are less vulnerable to dementia. This involves elements of both the DASH diet, which is known to help control blood pressure, and the Mediterranean diet, which promotes cardiometabolic health. The multi-ethnic cohort study found the strongest protective effect was among Latinos, whites, and African Americans. Asian Americans and Native Hawaiians did not appear to benefit as strongly, although the researchers emphasize that many ethnic cuisines are compatible with maintaining brain health as we age.
The hottest drugs in the pharmacy have been the weight loss medications known as GLP-1 agonists. You'd probably recognize brand names Wegovy and Zepbound. Scientists recently reported that these drugs can increase testosterone levels. More than 200 men with either type 2 diabetes or a diagnosis of obesity received a prescription for a GLP-1 agonist. Only half the men had normal levels of male hormones at the beginning of the study. After losing around 10% of their body weight, 3/4 of the men had achieved normal testosterone. Weight loss may be the most important reason for healthier hormone levels.
A new study confirms that erythritol, a natural non-nutritive sweetener, could produce some serious complications. Prior research showed that erythritol increased the risk of blood clots that could lead to heart attacks. In addition, it impairs the ability of endothelial cells lining blood vessels to produce nitric oxide. New research confirms that erythritol also affects endothelial cells in tiny blood vessels of the brain, which may increase the risk for strokes. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon. I'm a medical anthropologist.
And I'm Joe Graydon. I'm a pharmacologist. Today, our lines are open for your calls and questions. Have you been dealing with bites, burns, or perhaps blisters? We're all having some kinds of summer skin problems, but we'd like to hear from you.
We are pleased to have here in our studio a special guest. Dr. Chris Adigun is a board-certified dermatologist and founder of the Dermatology and Laser Center of Chapel Hill, North Carolina. She specializes in both nail disorders and laser treatments. Welcome to the People's Pharmacy, Dr. Adigun.
Thank you, Joe and Terry.
Do you have a summer skin problem that's been pestering you? What about a success story? Do you have a surefire remedy that works to get rid of warts, nail fungus, or ease the pain of a bee sting?
Our phone lines are open for your stories, comments, and questions. The number is 888-472-3366. If you prefer, you can email us. It's radio@peoplespharmacy.com, or you can find us on Facebook or at People's Pharmacy.
Again, that phone number, if you'd like to join the conversation, 888-472-3366.
Dr. Adigun, we understand you are just back from Switzerland, and it wasn't just a vacation. It had everything to do with skin cancer. Tell us about it, please.
Yes. So I was just on the Skin Cancer Take a Hike. The American Academy of Dermatology supports this program. And what we do when we are joining Skin Cancer Take a Hike is not just hike, 15 miles a day in the mountains, but we are all that are participating, raising money to support programs that promote prevention of skin cancer and early diagnosis of skin cancer. Early diagnosis of skin cancer, of course, is the best predictor for your prognosis.
And what was it like?
It was extremely challenging, also totally inspiring. Being around other dermatologists across the United States that are also moved to take time out of their lives and seeing patients in their practices, really just to hike, to raise money to support these incredible programs, it's really inspiring.
And tell us a little bit about why this is so important, why awareness from the public, as well as not just dermatologists, your other colleagues in medicine, because it seems like there's an epidemic of squamous and basal cell carcinoma out there. And of course, we all worry about melanoma because it's so deadly.
So basal cell carcinoma and squamous cell carcinoma are the two most common types of skin cancer. And all these skin cancers are directly related to UV radiation exposure over the course of your lifetime. Melanoma is the least common type of skin cancer, but also the most deadly form of skin cancer. So even just having this dialogue can be so helpful to help people understand that there's more than one type of skin cancer. Whereas basal cell carcinoma is the most common cancer period. When these skin cancers go untreated, they can have a negative effect on that patient's quality of life.
Now, you did talk about early diagnosis, so probably the earliest diagnosis is going to be if the patient notices something. What should patients be looking for? Not patients. What should normal people who have skin, which is all of us, be on the lookout for?
And that's a really great point. I like to think that most of the patients and people that come to their doctor, they've actually already done all the work, right? They have noticed that something that is awry in their body. With basal cell carcinoma and squamous cell carcinoma, it's actually very unusual for them to carry pigment. So a new skin cancer is not necessarily always a dark spot. They are less likely to be a dark spot. They look as asinine as a pimple. So that's what I will actually use that term, because a lot of people know what a pimple is. So something that looks like a pimple but doesn't go away. Pimples will go away. Kind of a quick rule of thumb is most of the time your skin will heal within a month. So if something on your body does not heal within a month, it's a reason to have it checked out.
What else does it look like? Give us a few little tips so we can be paying closer attention.
A tiny red bump that might be painless, a scaly red spot that also might be painless or sensitive, something that bleeds easily with very minor trauma. So let's say you get out of the shower, you're just doing your usual towel pat down and your skin starts bleeding. It is not normal for your skin to be that fragile. So those are all kind of quick and easy warning signs.
And the more serious melanoma, what should people be looking at there?
So what I often describe is that we make most of our moles, which are round brown spots on our bodies, between the ages of 15 and 35. Sure, we make some before 15, we make some after 35, but everything really slows down. So a new dark spot on your body after the age of 40 generally should be evaluated.
Now, I have a wild idea here. It's a little bit heretical, but when Terry and I were kids, there
was no sunscreen. Let's just put it out there.
Well,
we're old.
There were those cute, they were like billboards of the dog pulling
the Coppertone baby.
Mm-hmm.
And, she was tan except for where her diaper had been and the dog was pulling it away.
Right. And so, but they weren't effective. It was mostly, cocoa butter or something ridiculous. And then along came sunscreens. But we learned if we went out in the sun and spent, a couple of hours, we would get burned. Oops, and it hurt.
It hurt. It was painful. Yeah.
So we learned you couldn't do that. Well, then along came those early sunscreens, and you could spend all day in the sun. Wow, cool, fun, no burn. Did that increase the risk of skin cancer? Because those early sunscreens blocked what we call UVB, not so much UVA. So you could spend hours out there and you could be getting a lot of UVA exposure. And I'm just wondering, do we have an explosion of skin cancer in part because we could spend so much time out in the sun?
And the answer is potentially, right? Until it's officially studied, but potentially I think the theory is a strong one. UVB rays are it's just a fraction of the percentage of UV rays that reach the Earth's surface. The large majority are UVA rays. Those are considered the mutagenic rays. They penetrate the skin more deeply and are more likely to cause the DNA damage that evolves into skin cancers. But what UVB rays do is burn. So if you block the burn, it does help you feel safer out in the sun. And it is possible that by using these kind of early UVB blockers, you were able to prolong your time that you could spend in the sun before getting that nasty and uncomfortable sunburn. So more UVA rays, makes sense that potentially more mutagenic ray exposure, more skin cancers.
Now, you've just been talking about Switzerland. As we understand it, Europe has been far ahead of the U.S. in terms of sunscreens that block UVA. Is that true?
It's tough to say. We have a lot of really excellent UVA blockers here in the United States. They do not have the chemicals that are used in Europe are not regulated the way our chemicals are regulated in the United States. So we have more data on ours than Europe does. So I have a hard time saying one is necessarily better than the other.
Okay.
So here, a lot of dermatologists are now promoting zinc and titanium. What about you?
I would join those dermatologists primarily because zinc and titanium dioxide are minerals. They're just rocks, and they're ground up very fine, and you apply them to your skin, and they reflect the dangerous UVA rays. They also block a more complete portion of the UV spectrum. So chemical sunscreens, when you flip a bottle over and you see 5 or 6 ingredients, all with very long names, they each block just a portion of the UV spectrum, and they just need to get to a certain percentage of blockage of the UV spectrum to get that broad spectrum label. Whereas the zinc and titanium dioxide they block a large percentage of the UV spectrum with no gaps.
Do you have questions about sunblock? Have you experienced squamous or basal cell carcinoma? What about melanoma? Join the conversation. Our lines are open, 888-472-3366. You can email us and let us know where you're coming from. Email us at radio@peoplespharmacy.com. We also welcome your Facebook posts. That's at People's Pharmacy.
Now, Joe, do you want to take any questions that are not sunscreen related right now?
Let's do that in the next segment.
In the next segment,
Yeah.
okay.
But I do want to ask about some other ways to prevent sunburn. Hats and sunblock clothing, because that can make a big difference.
I would say it makes the biggest difference. So UPF clothing, and that's the UV protective factor clothing, is incredibly effective, doesn't wear off. You don't have to reapply. And it's not just filtering rays, it's truly blocking rays. Whereas the sunscreens, the best they can do is filter. So, I mean, if you'll talk to any dermatologist, they are more likely to cover up than lather up with sunscreen because it's just so much more effective.
And those shirts and pants and what have you are all becoming a lot more popular now. I've seen a lot more advertisements for such clothing.
And I would say that the designs are a lot more stylish now than they used to be, which I think also makes them a lot more appealing.
Well, including long-sleeved swimsuits, which, we would have thought back in the day, we would have thought that was weird.
And now they're not so weird.
They're stylish.
Yes.
So lather up and wear a hat.
Cover up.
That's right.
What about your eyes? Because I think a lot of times people don't think so much about the eyes and the effect of UV radiation on the eye.
That's correct. So wearing protective sunglasses is really important, primarily because your eyes do sustain UV damage, which can lead to early onset cataract formation. So yes, your eyes are important.
So our lines are open for your summer skin questions. You can email us, radio@peoplespharmacy.com, or join the conversation, 888-472-3366. After the break, we're going to expand our repertoire. We're going to talk about bug bites and blisters and rashes and rosacea and whatever is on your mind.
And the lines are open, 888-472-3366.
And again, that email address, Terry?
That email address is radio@peoplespharmacy.com. You're listening to The People's Pharmacy with Joe and Terry Graydon. This podcast is brought to you in part by Sonu.
Ready to breathe like never before? Meet Sonu, S-O-N-U, the world's first FDA-approved wearable headband that gives you drug-free relief from nasal congestion in minutes. It's safe for adults and kids 12 and up, making it perfect for families dealing with allergies, sinus issues, or chronic stuffiness.
Sonu uses personalized sound-based therapy to naturally open nasal passages. No meds, no steroids, no sprays. Even better, up to 4 users can share one account, so the whole household can benefit. Compatible with both Apple and Android smartphones.
Learn more at getsonu.com. That's G-E-T, get, S-O-N-U, Sonu.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, a sound-based alternative to steroids. More information at getsonu.com. That's getsonu.com.
Today we're talking about solving summer skin problems. Have you been bothered by bug bites? Sidelined by a blister? Our guest can answer your questions. Dr. Chris Adigun is a board-certified dermatologist and founder of the Dermatology and Laser Center of Chapel Hill, North Carolina. We consider her the People's Pharmacy dermatologist.
And we invite your questions and your stories, 888-472-3366. Our lines are full. If you can't reach us by phone, you can send us an email. It's radio@peoplespharmacy.com. Let us know where you're sending your message from. You can also use Facebook. We're at People's Pharmacy.
And we go to Columbia, South Carolina, and talk to Valerie. Valerie, what's on your mind?
Hi. My concern is I have a granddaughter. She's about 5 years old, and she has been battling eczema since the age of 2. And I wanted to know what would be the appropriate sunscreen for her to use, when she's out playing. And we do make efforts to try to keep her clothed appropriately, keep her in the shade, cooling moments, a lot of hydration. But it doesn't seem to be really working well. And are there any new treatments for eczema that she could use?
Okay, thank you so much, Valerie. First, Dr. Adigun, what is eczema? What does it look like? And does it get worse in the summer? And what about sunscreen?
So eczema, when it's diagnosed as young as Valerie's granddaughter, is known as atopic dermatitis. It's an immunologic condition that causes disruption of the skin barrier. So treatment is oftentimes directed at both that inflammation that caused that immunologic disruption, as well as barrier repair methods or barrier protection. And she specifically asked what type of sunscreen can they use on their granddaughters so that she can go out and play with the other kids. And she's already doing a lot of things right. They're trying to cover her up as well as treat her atopic dermatitis effectively. What that barrier disruption does is causes tiny little openings in the skin barrier. And as a result, that skin with these tiny little openings in skin barrier is going to react to more allergens in the environment. And so the chemical sunscreens do have potential allergenic effects. So I oftentimes tell patients with active atopic dermatitis to avoid those sunscreens and instead use the mineral-only sunscreens. So what does that mean? Valerie goes into the drugstore to buy some sunscreen for her granddaughter. You're going to flip over the bottle to look at the ingredients, and you want the only active agent to be zinc and or titanium dioxide. Usually it's zinc oxide by itself or zinc oxide with some titanium dioxide. Those, again, are ground up rock and non-allergenic.
So if you see octocrylene, avobenzone, homosalate, octinoxate, blah, 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 oxybenzene,
Oxybenzone, yes.
Benzone, skip those.
Skip those. And it doesn't mean that all of those chemicals have problems. It's just very unusual for not all of them to be on the bottle, right? So I can name which one of those chemicals are more likely to be problematic, but it is easier just to avoid all of them and stick with the mineral-only based sunscreens, which do exist.
And we go to Paul in Deep Creek Lake, Maryland. Hi, Paul. Your question.
Hello.
Hi, Paul.
Yes, hello.
Go ahead.
My question is, about 5 or 6 years ago, I had a basal cell carcinoma removed on my bicep. I spent a lot of time in the sun as a winemaker, and now I have a spot that's very similar. Again, I'm going to have checked out in 2 weeks. My question is, does having a spot like that increase one's odds of a recurrence in the same area, or is it, not any more prone than any other part of your skin?
So yes, is the short answer, that you're more likely to have recurrence at the site than you would in normal skin. right? So if you have a basal cell carcinoma on your bicep, like you said, and you had it treated, every time you see your dermatologist, they're actually not just checking everything else, all of your normal skin, but they're also checking that site to check for recurrence.
So it sounds like, Paul, you need to be vigilant because you do not want to let that basal cell keep going.
And we've got an email from Sharon who says, do you recommend, Dr. Chris, she says, do you recommend using a skin peel chemotherapy treatment for someone who has had face or neck and basal cell carcinoma?
The answer is yes. And I just want to clarify what she means by skin and peel chemotherapy treatment, because really it's not a peel. It is a cream that contains a chemotherapy known as 5-fluorouracil. And in cream formulation, we use it extremely commonly in dermatology, primarily because it is so effective. Now, 5-fluorouracil was first used to treat cancers, internal cancers, and it was given by IV. But we use it compounded in a cream to treat precancerous change and sometimes early skin cancers on the skin. So whether it's your head and neck that sustain the most UV radiation, or your arms and hands, or you name it on your body, we can use this cream on anywhere on the body for this reason.
And how effective?
It's extremely effective. We use it, again, primarily for precancerous change, which are known as actinic keratoses or actinic disease. But sometimes we do use it for early skin cancers on the body.
Can you distinguish between squamous and basal cell cancer? Because, I think most people go, oh, yeah, nothing to worry about. It's the melanoma I need to be concerned about. But you don't want to let either of those go.
I will differentiate. I think it's important. So basal cell carcinoma and squamous cell carcinoma are both derived from portions of the skin. They're what we call keratinocyte skin cancers. It just depends on which keratinocytes that they derive from. Basal cell carcinomas do not tend to metastasize. It's pretty rare for them to metastasize, so they don't invade the body and then go spread somewhere else. Although they can, it's unusual. But they will continue to grow locally and cause a lot of destruction to local tissues. Squamous cell carcinoma, on the other hand, can metastasize. The highest risk areas are on the head and neck region, and so we are very vigilant about treating the squamous cell carcinoma as well.
Again, help us know what to be looking for.
So these types of skin cancers often do not have any pigment, and so they don't often look brown. They're more likely to be kind of the color of your skin, but a little bit lighter, a little bit darker, and red, right, or pink. And they will oftentimes bleed easily. They're a bump that wasn't there before, something of that nature that really just doesn't look like normal skin.
888-472-3366 is the number to call if you'd like to join the conversation. Do you have a question about poison ivy or
bug bites? But Linda in Greensburg, Pennsylvania has a question for her. Dr. Adigun. Linda, go ahead. Oh, Linda, I'm sorry, we can't hear you. We are going to have to ask Linda to call back.
Hello?
Wait, there she is.
There you are.
Hi, Linda.
Hello? Yeah, thank you for taking my call. I have two questions. I get these real small red dots every now and then on my skin. They're not completely all over the body, but mainly in the midsection. That's the first question. Like they're real small dots. And then my other question is what would you recommend to older people with wrinkling skin?
Okay. Two important
different
questions.
All right. Red dots could be all kinds of things, right?
Right. I mean, this is almost impossible to diagnose over the radio. But Dr. Adigun?
Tell us about which red dots we should worry about and what we should do to make sure they're not the wrong kind of red dot.
So I think she specifically talked about red dots around her midsection.
Yes.
Linda did. And those tiny red dots might arise because she has her waistband quite tight, causing rupture of superficial vessels. And so it can look like a little band of dots around her waist. I mean, it's quite tight and it would have to be rubbing. I mean, not all that common. But red dots on the skin that can be problematic might be related to a drug reaction. So that would probably be my biggest concern if Linda were to come in with new red dots all over her midsection. that would be kind of the worry.
So that would be something she would want to see her doctor to rule that out.
That's correct.
I'm so glad you mentioned that because I think a lot of people don't realize that medications can cause rash. You hear it on the commercials a lot, but I don't think people take it that seriously. They can also make you more vulnerable to the sun. So diuretics, they're commonly prescribed to lower blood pressure. HCTZ, hydrochlorothiazide, is number one, but there's a whole bunch of other ones that people often have included in their blood pressure medicine. And they can increase the risk for skin cancer because they make your skin more vulnerable to the sun. But statins, that they can also make the skin more sensitive. And there are several other very commonly prescribed drugs like NSAIDs that can also do it. And almost everybody is taking an NSAID for their aches and pains, like Motrin or Advil or Aleve. We could go down the long list. So a quick overview of medications that sensitize the skin and what people should do if they're taking one of those drugs.
I think that it's really important just to be aware whether or not your medications are photosensitizing, just like you said. Photosensitivity is not an uncommon side effect of many medications, whether they're antibiotics, they are antihypertensive, or cholesterol-lowering agents. There are certain ones that all do it. And you're really going to do best with more sun protection when you are going out of doors. You have to kind of reframe your mind. Okay, I'm getting more UV radiation than I would have if I were not on this medication. I think that people that are not accustomed to worrying about UV radiation are really most vulnerable. So people that have always tanned easily and didn't get that negative feedback from sunburn, they're the ones that are going to suffer more because it's already not part of their routine to protect from the sun.
Now, while we're talking about sun protection, we have an email from John in Holly Springs, North Carolina. He says, don't long-sleeve cotton shirts protect you from the sun?
The short answer is yes, long-sleeve cotton shirts do protect you from the sun, but not very well and for not very long. So, and there's so much variability from one long sleeve cotton shirt to another long sleeve cotton shirt that it's tough for me to quantify.
Sure.
Based on that knit and the thickness in the fabric. But if you prefer the feel of a cotton shirt to kind of a UPF 50 shirt, which sometimes doesn't breathe as well, you can actually buy a product that you put in the washing machine with your cotton shirts that will coat it with sunscreen.
That brings up another question that a caller had, which was, if you wash your UPF clothing, does it wash out the protection factor?
The short answer is it likely does. It's tough to say for how many washes. Also, throwing them in the dryer will expedite kind of the breakdown of the sunscreens that's woven into the fabric.
So you might want to put them. You might want to dry them in the air.
That's correct. So that's kind of the quick rule of thumb.
You're listening to Dr. Chris Adigun. She's a board-certified dermatologist and founder of the Dermatology and Laser Center of Chapel Hill, North Carolina. She specializes in both nail disorders, and we'd love your questions about nail issues, and laser treatments. That was the other question. What about wrinkles?
So wrinkles are formed over time, primarily due to chronic UV radiation, and it causes a complex structural breakdown of the structural components of the skin. So different types of treatments that try to kind of stimulate your body to make new skin is really the best way to treat wrinkles. And the most often in a dermatology office, we're going to use laser tools to use lasers to stimulate your body to make new skin. So we use that with heat and specific wavelengths.
Okay, and now we have a question from Susan in West Liberty, West Virginia. Susan, go ahead, please.
Thank you. I love your program for decades now.
Thank you.
I have lots of poison ivy on the property. I have long grass, which has been a place for ticks, and my legs were just itching and itching and itching with the poison ivy, and I put Caladryl on that, and then it was still itching, and then I realized that there was a tick in the skin, and it had been days, and there was another spot, looked like a little black pimple, but it wasn't. It was a tick body, and I can't get it out. And it's been days, and they're not symptomatic of Lyme's disease, which has that target, and I've had Lyme's disease twice. So is there a danger of having this tick body in my skin for the rest of my life, or what?
So it sounds like you were doing some at-home tick removal, and you got at least a portion of the tick removed, but what remained in the skin is the tick's head. Now, whether or not you could potentially get a tick-associated illness from this tick, you've actually already been exposed, whether you removed the head or you didn't. But the problem with leaving the head in the skin is that it can cause a local immune reaction that can be very, very uncomfortable. It causes that little tick head, your skin knows is not part of you. And so it calls inflammatory cells to come to that area, which means that the skin never really heals over. So you're at risk for both infection as well as chronic inflammation. So I do think it would be important to get into the doctor to have that tick head removed.
Yes, this may not be a do-it-yourself home kind of surgical process. So, yes, maybe it's time to see the dermatologist and have it removed once and for all. But that does bring up the issue of avoiding both poison ivy
and ticks.
So what do you recommend, doctor?
So it sounds like she lives in a very beautiful area with this long grass, but she's right that this area with trees and long grass and these plants, there's all kinds of things that can happen when you're out in it. So poison ivy, poison oak, poison sumac, they all are of the toxicodendron family, and all of them have urushiol, which is a very potent allergen. So the best way to avoid it is with clothing, right? Clothing protection will do the best job. Once you've developed a poison ivy type reaction, then you're going to need different types of topical anti-inflammatory agents. Often the prescription ones work best, but avoiding it is best. So long clothes, long pants.
And once you've been out, you have to treat those clothes like toxic waste.
You're going to throw them right into the wash with
exactly, because otherwise that urushiol is there and it's waiting for you the next time you put on your clothing.
And the best way to prevent tick bites and chiggers and all those other nasty things waiting to bite you?
So you can use, clothing, tucking your socks, tucking your pants into your socks so that they, really can't find any way to crawl up underneath your pants, with both ticks and chiggers can do. And then there's insect repellents. This is when things can get a little bit tricky, is when you're using insect repellent and sunscreen at the same time.
Oh, yes. Please do tell us about that.
Okay, so you want to avoid the combo products. It sounds so easy, but the reapplication of sunscreen versus the reapplication of a insect repellent is very, very different. So if you're out and you're sweating and you're having a great time, you're going to need to reapply that sunscreen every 2 hours. Whereas DEET, which is one of our most effective insecticides or insect repellents, is every 6 hours.
And we need to take a short break. When we come back, we will take more of your questions about blisters and bug bites and all the sorts of things that can happen to you when you're outside in the summertime.
Our lines are open, 888-472-3366. You can email us, radio@peoplespharmacy.com. Tell us where you're contacting us from, or use Facebook. We're at People's Pharmacy. Again, 888-472-3366.
You're listening to the People's Pharmacy with Joe and Terry Graydon. This episode of The People's Pharmacy is brought to you in part by Caraway. You can equip your kitchen with cookware that works well, looks great, and doesn't expose you to plastic or toxins.
I love being able to make our favorite breakfast of refried beans with sautéed onions and an egg in our Caraway frying pan. It cooks perfectly, and cleanup is so quick and easy. No scrubbing and no worrying about PFAS compounds like PFOA. Caraway doesn't use them. That's different from most nonstick pans, which we don't allow in our kitchen.
Another thing we don't use ourselves and don't want you to use, plastic cutting boards. Every time you slice an onion on a plastic cutting board, you're creating tiny particles of plastic that you then ingest. The average American consumes the equivalent of 12 plastic bags a year. Ugh!
Caraway offers birchwood cutting boards and utensils, too. Keep those plastic spatulas out of your kitchen.
If you've been eyeing their internet-famous 12-piece cookware set, now is the perfect time to buy. You can shop Caraway risk-free. Enjoy fast, free shipping, easy returns, and a 30-day trial. Plus, if you visit carawayhome.com/PPOD, you can take an additional 10% off your next purchase. This deal is exclusive for our listeners, so visit carawayhome.com/PPOD or use code PPOD at checkout. Caraway, non-toxic cookware made modern.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-cleared drug-free treatment for nasal congestion and runny nose, a sound-based alternative to steroids. More at getsonu.com. That's getsonu.com.
We have Dr. Chris Adigun here in the studio today. She is a dermatologist. She practices general and cosmetic dermatology at the Dermatology and Laser Center of Chapel Hill, and you specialize in nails as well as skin. So, tell us, what is the best way to get rid of nail fungus?
Oh, toenail fungus. It's always among us. Everyone wants to talk about the toenail fungus.
Especially now because we want to wear our sandals.
In fact, we have a Facebook question from Angela. She says, athlete's foot and toenail fungus, are they related?
Actually, she just brought up the natural history of the disease. So yes, your toenail fungus, you contract from your very own athlete's foot. You catch it from yourself. A lot of times people like to blame the nail salon, but what can happen at the nail salon is you can have a little wound around your nail while you're getting your pedicure, and your very own athlete's foot then is able to invade that wound. So yes is the short answer. You want to not prevent toenail fungus, you want to treat your athlete's foot.
Okay.
And again, how do we get rid of either athlete's foot or nail fungus? Because we've got dozens of remedies. Some of them work, some of them don't, but it's very individualized. Some people get great benefit from Listerine, the old amber-colored Listerine, and white vinegar, and other people say, didn't work at all.
So the treatment for athlete's foot, or what we call tinea pedis, is really quite different than toenail fungus, which we call onychomycosis. And treatment, I think that a lot of times what people don't realize is that treatment for your athlete's foot is ongoing. You've already shown that you have the propensity to grow these, what we call dermatophytes, which are fungi that live and grow only on the skin. So yes, you're going to use an antifungal agent. There's a lot of topical antifungal agents available at the drugstore.
Your favorites?
So products that contain terbinafine or different types of azole antifungals are often all very effective for athlete's foot.
Ketoconazole,
clotrimazole is maybe the most widely available from a topical standpoint, and it's extremely effective for athlete's foot as well as different types of yeast infections, even in the vulvar area. So it really is, it kind of checks a lot of boxes. But you're going to have to treat again because over time it's going to come back. So I think that that's the main educational piece, is that knowing that it doesn't mean the treatment didn't work. If you used it, your rash went away, and 2 weeks later it came back. Treatment indeed did work, but maybe...
Especially this time of year.
Especially this time of year, there's more moisture between your toes, and oftentimes even on your body there's a little bit more oil formation, which fungus loves. So it doesn't mean the treatment didn't work. It just means that you're going to need to do this, for some people several times a year.
To maintain.
And jock itch, same thing?
Same thing. And so using the creams can actually be very effective, and you want to treat until you're totally clear and just be prepared to treat it again. Because again, your skin loves to grow this. It's kind of like, well, why doesn't everyone have jock itch? Why doesn't everyone have athlete's foot? That's because not everyone has the receptors. This tends to run in families. So you are either a mossy tree or non-mossy tree.
And if you want to get nail fungus gone?
So nail fungus depends on the severity of this disease with how we treat it. For very, very mild cases, which means really like less than 30% of one solitary nail affected, we can use one of the prescription topical agents. Oftentimes, we have to use oral for any cases more extensive than that.
And we will have to be patient regardless of what treatment we're using. Why?
Because it takes 12 to 18 months to regrow a toenail. So whatever treatment you're doing for a very long time. Because you have to treat until that entirely diseased nail is gone.
I've got an email from Lisa in Sarasota, Florida. Retinol. By using a retinol at night, am I weakening my skin's barrier against the sun, even though I use a mineral-based broad-spectrum sunscreen? However, the heat is intense in Sarasota. What about this idea of retinol? What is it, and why would it be a potential problem?
So retinol is a form of retinoic acid, which is derived from vitamin A that we use in skincare products because it's so effective at promoting healthy turnover of the skin. And so it also stimulates collagen formation and all of these great things. From a topical agent after sunscreen, because sunscreen is number one, we do recommend vitamin A derived agents such as retinol.
Are they available over the counter or just prescription?
Retinol is available over the counter. To have the most potent form, which is tretinoin, that does require a prescription. For this patient in Sarasota, I would say keep up the good work. She's doing retinol at night and wearing a mineral-based sunscreen in the morning. She's doing a lot to keep her skin healthy. I would not think that she would have really any measurable notice any measurable change as far as her sun sensitivity. That being said, because there's skin that retinols do promote that healthy skin turnover, you do not have a layer of dead skin sitting on the surface of your skin that gives you a minuscule amount of sun protection. So the short answer is no.
Okay. Well, we've got a question from a call from Ben in Shady Hills, Florida. It sounds a little complicated, but quite interesting. Ben, please tell us your story.
Hi. I've got a number of difficulties that should make me a very good customer for dermatology. I have vitiligo. I live in Florida. I was a lifeguard as a teenager, and I'm from Eastern Europe. So the combination of all of these things, and then last week, I really messed up and did some welding, arc welding, without my arm sleeves, and I developed brown spots all over my forearms, which seemed to rise to the surface and then flake off and disappear and then reappear within a day or so.
Well, Ben, you have really gotten yourself into a pickle. Dr. Adigun, what can we recommend or suggest for Ben between his lifeguard stuff and his welding and his genetic background? Give us some ideas here.
He sounds like someone that really should have, a routine skin examinations to kind of screen him for skin cancer development. That he just brought up several different individual risk factors. The vitiligo alone, those areas where vitiligo is...
What is vitiligo?
Vitiligo, what is it?
So vitiligo is an autoimmune disease to the pigment cells in our skin called melanocytes. So when someone has a patch of vitiligo, it looks like a white area on their skin. And if you take a little piece of that skin, you will notice that there's not a single melanocyte, which is one of our pigment-producing cells, that will be visible on that skin biopsy. So our melanocytes do produce pigment in our skin, which does give us some level of UV protection. So patients with vitiligo are at much higher risk in those active areas of developing a skin cancer.
We had an email earlier, a person who wanted to know, will the vitiligo areas burn more easily?
Yes, they will.
So they need to be extra protected.
So Ben's got this triple whammy. He's got vitiligo, which means there's no pigment in parts of his skin. He's got his European background, and he's got his arc welding, and he was a lifeguard. So he really needs to see a dermatologist.
That's right. The lifeguarding history alone shows that he had, over the period of time, a lot of UV radiation that was really kind of concentrated while he had that line of work. And I think that when he's saying he's of Eastern European descent, what he's implying is that his skin does not have much pigment, which obviously puts him at greater risk.
He's a pale-skinned person.
That's right.
Okay, good luck, Ben. And we expect you to make an appointment with your dermatologist in the next week or two, if not sooner.
Now, we have an email from Rahiqua in Dallas, Texas, who wants to know about sunscreen. And what she says, is there, Dr. Adigun, a specific sunscreen you recommend for brown skin?
I think this is a really great question for a couple of reasons. Number one, there can be the implication in our society from societal norms that if you have more pigment in your skin, that you do not need to protect yourself from the sun. And that's just false, right? People of all different levels of pigment can develop problems from the sun, whether they're diseases or skin cancers, and yes, need to still cover up from the sun and use sunscreens on the exposed areas. And the problem is that many of the sunscreens can leave an opaque gray or even blue finish on the skin. My own children have have more natural pigment. And then when I put zinc sunscreen on them, they call themselves blueberries, right? Because they look a little bit gray or kind of blue.
So what do you recommend?
Which is not appealing, of course.
That's right. So using products that have a blend of zinc oxide with some chemical sunscreens, such as the avobenzone, oxybenzone, or octinoxate or octocrylene. These are all different types of chemical filters.
These things we're otherwise avoiding.
That's right. When you kind of have a blend of the products, you can still have the benefit from the zinc. You need less of the chemicals, but it will be sheer and translucent and far more cosmetically elegant on skin with more richly pigmented skin.
Okay, well, Rahiqua, we hope that you got that recommendation. And now we turn back to the phones. Anne in Clover, South Carolina. Welcome to the People's Pharmacy.
Hi. I was interested in skin tags. I wondered if they are something you should see a dermatologist about, or if you should just cut them yourself, or just leave them.
Okay, good question. Self-treatment of skin tag. A lot of people do this, Dr.
Yes,
Adigun, and we always read, don't do this.
Right.
It's a terrible thing. I'm not so sure that it's as terrible as the official recommendations, but you can tell me differently.
Well, before you answer,
Let's
some
talk
people,
about what a skin tag is.
Yeah, what is a skin tag? And, a lot of people say, oh, just use thread, tie it off with thread. And there are now over-the-counter freezing products. Dr. Scholl has one. So what's a skin tag? Is it something to worry about?
So a skin tag, by medical definition, is what's called an acrocordon, and it looks like a little pouch of skin. That's really what it looks like. It has its own little blood supply, and it's this little out pouch of skin. But we make lots of other types.
And it sits on maybe a little stem, sort of.
Yeah, exactly. It's like a little sprout. But there's a lot of other tag-like benign entities that we grow over time as well. But a traditional skin tag is this little out pouch of skin called an acrocordon, and they're completely benign. But they can be a nuisance when they get rubbed. They can swell. They can hurt. Most of the time, snipping them off is what we do in the office under clean conditions so that the risk of secondary infection is low. If there's a way that you can do that at home, I think that'd be fine. Just keep the area clean with soap and water. Treat it like a wound that you would any other wound that needs to stay clean to prevent secondary infection.
What about those freezing techniques?
So the freezing techniques can sometimes work and sometimes not. I think that really the worst thing that can happen with the over-the-counter freezing is that it wasn't quite cold enough to cause that vessel to close and it doesn't fully come off.
We've been talking about skin. We've been talking about nails. I just want to take a moment to talk about hair loss. We talked with you a couple of years ago about oral minoxidil, very low dose. What's the latest from the world of dermatology?
I think one of the latest things since we had that session years ago is that there's many more people on low-dose oral minoxidil for their hair loss. Long story short, it does work. And a lot of people are having success. So from a professional gratification fulfillment standpoint, I'm so happy that we have low-dose oral minoxidil. Many of my patients are on it, and most patients do very well on it.
Side effect issues?
I think that One great thing about minoxidil is that it's an old medication that's been prescribed in high doses. It's prescribed in low doses. So we know a lot about it. So we know so many of the potential side effects. So there's no surprises. But the most common side effect from low dose oral minoxidil, by and large, is unwanted hair growth on the body and face. So that is something that I always talk about with patients. Otherwise, it has also been studied, like how much can it lower your blood pressure? These doses are so low that's actually very unusual.
Tell us about the dose.
So low dose oral minoxidil is a very broad term that ranges from 0.25 milligrams all the way to 5 milligrams per day.
And the blood pressure medication dose is somewhere in the 30 to 50 milligram dose. So this is much, much smaller. And this is the same drug that's in Rogaine. Am I correct?
That is correct. So Rogaine is just a topical formulation of minoxidil. And there's everything from 2% to 5% topical minoxidil available over the counter. There's actually a recent study comparing the effectiveness of low-dose oral minoxidil head-to-head with topical 5% minoxidil applied twice a day, and the results were not significantly significant. But what I tell patients is that keep in mind these people were doing the topical minoxidil every day, twice a day, every day, twice a day. If you cannot keep that up, then we should discuss the oral.
Okay.
We have time for one more question, Terry.
Well, how about if we ask the question that was submitted by email by Mark? And Mark says, how much tan? I am careful about excessive sun exposure. I always wear a hat, but inevitably I get a mild tan on my face and neck. Is this an acceptable risk? I'm 74, a pale-skinned male, and I have irregular precancers that show up on the top of my head. So, anything for Mark?
So Mark is bringing up a very good point that he has regular precancerous change on his scalp. That's known as actinic damage, and that is high risk for squamous cell carcinoma development, ultimate squamous cell carcinoma development, which also means that he's sustained an enormous amount of UV radiation over the course of his lifetime. And so I would say that he should avoid tanning of any level whenever possible because he's already sustained so much UV radiation to begin with.
So if he's getting a mild tan on his face and neck, even though he's wearing a hat, maybe he needs to wear sunscreen too?
Yes, or a broader brimmed hat.
Okay.
We just have time for one last question. Swimmer's ear. How to prevent it?
So swimmer's ear is actually an infection of what we consider the external ear. Now, that's what doctors call it the external ear, but patients, the pain is inside, right?
Yeah,
but that
right.
ear canal is considered the external ear. And the best way to prevent it is to keep it dry. So as soon as you get out of the pool, you're going to use desiccating drops. So different types of drops that evaporate very quickly. They contain alcohols. White vinegar is also used. You do the drops directly into the ear canal so that it will rapidly dry that wetness.
And that is all the time we have today. We want to thank you for listening, for sharing your questions and your stories.
And thanks to Dr. Chris Adigun, who is a board-certified dermatologist. She practices general and cosmetic dermatology at the Dermatology and Laser Center of Chapel Hill, North Carolina.
The People's Pharmacy is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
Lynn Siegel produced today's show. Pamela Alberta and Ayase Chinflu provided technical assistance. Al Wadarski engineered. The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Sonu, an FDA-cleared drug-free treatment for nasal congestion and runny nose, a sound-based alternative to steroids. More at getsonu.com. That's getsonu.com.
Today's show is number 1438. You can find it online at peoplespharmacy.com. You can subscribe to our podcast through your favorite podcast provider. We post the show on our website on Monday morning. That's where you can share your thoughts about this show and share additional stories about your interactions with the sun.
With the sun, yes.
Email us your comments, radio@peoplespharmacy.com.
If you go to peoplespharmacy.com, you can sign up for our free online newsletter. It's an easy way to stay on top of breaking health news. By subscribing to the newsletter, you also get regular access to the weekly podcast. You can find out ahead of time what we're going to be talking about. Speaking of the podcast, we would be grateful if you would write a review, preferably a really favorable review of the People's Pharmacy, and post it.
Any review is welcome, whether it's favorable or not.
And do post it to whichever podcast platform you are using.
Yes, and we've been putting up videos on YouTube TV, and so if you would like to see some of our podcasts and kind of a preview, just go to the People's Pharmacy at YouTube, and you can see Joe and Terry doing some strange kinds of things, talking about a whole variety of very common problems. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.